Hello, everyone. Welcome to our meeting. Today we'll have different topics, but we have a fellow who was in this program before. So we're going to start with that first, and then we're going to go over the agenda. I'm going to share the agenda. So we will talk about delirium, the main topic, but we will go over other topics as well later on. And we have new fellows, so I'm going to stop the sharing. Welcome to the program, to all the fellows, the new ones. So the first speaker will be Dr. Esraa. Please, when you are ready, share with us your experience and if you have any tips or any perspective that you can help others. Thank you so much. Go ahead.
Assalamu alaikum. I'm Dr. Esraa. I recently graduated from NEJM University in December. Actually, I'm new to it's my first time attending the meeting, and I don't know how it works and how the sessions go, but I've heard a lot about the fellowship and how impressive the work is. I joined, but my friend told me about it, and I joined through her. It seems like you guys are doing really amazing work. I don't have anything more to say, but if you'd like to ask me anything, feel free to.
Thank you so much and welcome to the program. So we're gonna go over some of the details about the program later on today, and we have some videos in the app that also the new fellows can refer to understand the concept of this program. It's a unique program, but we'll go step by step and hopefully everyone will benefit from this program. It's a sharing process, so you are expected to learn, but also in the future, we expect you to teach some of the new fellows down the road. So without ado, I'd like to ask also Dr. Esraa Mohamed, if you are here, please share your experience and if you have any tips. Thank you.
Hello, everybody. I hope my voice is clear to you guys. So my name is Esraa Mohamed Osman. I graduated from University of Khartoum at 2018. I also did my internship there. And then after that, I started my USMLE journey. I specifically joined the fellowship between May and June. Before the match season that was like a year ago. I matched into internal medicine at Englewood Hospital. The last match season. So regarding my journey, I started like a USMLE after my internship. I did the step 1 and step 2, and then I did my OET. That was after the war. So after the war, I was like searching for stuff to do that can improve my CV. As well as like research work. I did already publish 2 researches before the fellowship, but the fellowship also like give me a lot of experience in terms of research. It also was like a very about it was a highlight of my CV in general. So I got 3 interviews, and literally in each interview they asked me about this fellowship. I also had like a lot of connection who did the same fellowship and also matched in several programs. So it's basically very important for you guys to know how to speak about it in your CV, especially if you're applying like maybe next year or the next seasons. Because I remember one of the program that I interviewed with, like, was literally saying, the program that was literally saying that they interviewed me just because they want someone who has research experience, and the fellowship was like uh, one of the most reasons that like why I got this interview. So you have to know about the fellowship in and out. You have to do a lot, like if you can, like a research publication, either just like any presentation. Um, Even if the research is not published yet, it's not a big deal, but it really was very important in my CV. The other stuff is the connection that you can get from the fellowship. There are a lot of Sudanese, Sudanese and non-Sudanese people who match from this fellowship, so you can connect with your other fellows, senior fellows who graduated from the fellowship and match it to different programs. So it basically opened a lot of doors to you. You just have, it's just like how to take it seriously and how to get the most benefit out of it.
Sounds good. Thank you so much, Dr. Esraa, for sharing this perspective of yours. Do you mind if you maybe explain some of the answers when they ask you about the fellowship? What were your answers briefly? Like, what did you highlight? What did you share with them, the program directors or the faculty, during the interviews, the 3 interviews?
Yes, sure. So basically, they asked me about the fellowship in general, like what the activities that you do during the fellowship. Is it in person? Is it virtual? And they asked me also about the other non-research activities, like the grand rounds in University of Michigan, and also the weekly session that we do in the fellowship. I remember that I did one presentation during my fellowship, and I remember my presentation was also about how to do interview, which literally was like a mini training for how to do the interview. So it was really helpful to me. So they also asked me about if I did any research with the fellowship. At that time, I started only one, but after that, I wasn't able to finish it. But they asked like if you have any research about the activities in general. They also asked about like how to perform research or the strategy or to start a research question. Um, but basically, that's it. That was the most of the questions.
Thank you so much for sharing again. Any questions for Dr. Esraa from the fellows? Please feel free to raise your hand or go ahead and ask if you have any question or comment. So, Dr. Esraa, do you mind if you share your email, maybe contact info in the chat? So if someone wants to reach out with some questions, maybe you can help them.
Yes, I'm get it right now.
So I'd like to thank you so much, Dr. Esraa, for sharing your experience with us. And I wish you all the best. And hopefully we'll hear good news when you graduate, and maybe you can help us down the road as well. I wish you all the best.
Yes, sure. Thank you so much, Dr. Nader.
Thank you.
Easy.
Good luck. Thanks. Have a good one.
You too. Bye. Bye.
So for the next item, In the agenda, we will go over delirium. Do we have a speaker ready?
Hello, everyone. This is Dr. Nadine Alamat. I'll be talking to you about delirium. I'm going to share my screen now. I hope my screen is clear to everyone.
Yes.
Okay. So today I'm going to be discussing and talking about delirium, which is often an under-recognized but a serious condition, especially in those who are hospitalized and elderly. So in this presentation, I'll be going over the causes, clinical presentation, diagnosis, management, and prevention strategies. I believe that understanding this topic is very crucial for improving the patient's outcome and reducing complications. So first of all, I'm going to be discussing the definition and talking about the epidemiology of this disease. So by definition, delirium is an acute and fluctuation disturbance in attention, awareness, and cognition. It develops over hours to days, and it's often reversible if we actually know what is the underlying disease or underlying cause is. So the epidemiology is, it actually affects 20 to 50% of hospitalized elderly patients. Higher prevalence actually happens in ICU patients. It gets to up to 80%, the percentage, associated with increased morbidity, prolonged hospital stays, and higher mortality rates. So what is actually the pathophysiology of delirium? Well, key mechanisms goes over the neurotransmitter imbalance, especially acetylcholine and dopamine. Reduction in acetylcholine that actually leads to attention deficits. High level of dopamine contributes to hallucination and agitation. Another key mechanism is in neuroinflammation, which happens in infection, surgery, or systemic illness, triggering the cytokine release like interleukin-6, tumor necrosis factor alpha, and disrupting the brain function. Neuronal dysfunction by oxidative stress, metabolic imbalance like hypoxia, hypoglycemia, and the neurovascular dysfunction that contributes to the symptom. So this was an overview of the pathophysiology of delirium. Now I'm going to talk about risk factors and the precipitating factor. So there are a couple of predisposing factors that I'm going to be talking about in this slide. So first of all, as I mentioned in the definition, it happens mainly or more frequently in elderly. So advanced age being the first risk factor, especially above the age of 65 years. Dementia or a mild cognitive impairment. This increases the risk of delirium. History of a prior delirium episodes. Multiple comorbidities like heart failure or renal disease, and sensory impairment like vision or hearing loss. So what are the precipitating factors for delirium? One of them is infection like UTI, pneumonia, sepsis, surgery, and anesthesia. Polypharmacy, especially like benzodiazepine, opioids, anticholinergics, and ICU admission. As I mentioned earlier in the epidemiology slide, it happens like up to 80% of people in the ICU unit, and especially on prolonged mechanical ventilation. Another precipitating factor is electrolyte imbalance, like hyponatremia and hypercalcemia. So what do we expect to see in a patient with delirium? What are the clinical features of a person that has delirium? So there's a different types of delirium, but we have to know that it's acute cognitive disturbance and it has a fluctuating symptoms. So starting with hyperactive delirium, the patient usually presents with restlessness, agitation, hallucination, and delusion. Often linked to, this type is often linked to substance withdrawal or intoxication. Another type is the hypoactive delirium. Lethargy, reduced alertness, decreased speech and movement. This commonly happens in elderly and in ICU patients, but frequently overlooked due to the symptoms. Another type is the mixed delirium, which alternate between the two previous types, the hyperactive and the hypoactive state. Most common presentation in the hospitalized patient is the mixed type of delirium. So what are the key clinical signs? As I've mentioned, fluctuating course. So what does that mean? It means that symptoms wax and wane throughout the day. Inattention, difficulty focusing or shifting attention. Disorganized thinking, like rambling speech, confusion, poor reasoning. Altered consciousness ranges from drowsiness to hypervigilance. So how we're going to diagnose the delirium? We have DSM-5 criteria for delirium. Number 1, disturbance in inattention and awareness. 2, develops over a short period and fluctuates in severity. 3, additional cognitive impairment like memory issues and disorientation. 4, not better explained by any other pre-existing neurocognitive disorder. Number 5, evidence of an underlying medical cause. And then we have confusion assessment method, or CAM. For this method, it requires both acute onset and fluctuating course inattention, plus one of the following: disorganized thinking and altered level of consciousness, like drowsy, stubbornness, and hyper alert. So after we diagnosed the patient and we knew the symptoms and how the patient presents, now we're going to talk about the management of delirium. So first and most important, the non-pharmacologic management. So this is the first line in managing a patient with delirium. First, reorientation techniques, having the family being involved and constantly talk to the patient, orient them about the day, date, and where are they, talking to them, basically. Talking clocks, calendars, just keep the patient oriented. Reduce sensory impairment. If the patient has vision problems or hearing problems, make sure that they always have their glasses and hearing aids, because these patients, like most elderly, like have these kind of problems, and it makes it difficult for them to interpret sensory stimulus around them, which can make delirium worse. Encourage mobility and physical therapy. Optimize sleep. Minimize nighttime disturbance, and make sure in the morning, like you have the curtains on, they can see the light, and at the nighttime, make sure there's minimum noise and minimum disturbance, and reduce the light. Another way to management, non-pharmacologic hydration and nutritional support. So now we're going to talk about pharmacologic management, which is reserved for severe cases only. Low doses antipsychotics like haloperidol, QTP for agitation. Avoid benzodiazepine, especially except in alcohol withdrawal delirium. Treat the underlying medical issue that we've talked about, like infection or metabolic disturbance, or he has an electrolyte disturbance. If we treat the underlying medical cause, this could be reversible. And prevention strategies, how are we gonna, what are the modifiable risk factors to reduce the risk of delirium? Number 1, minimize unnecessary medication, especially sedatives and anticholinergics. Number 2, promotes mobility and early ambulation. Avoid physical restraints. Maintain hydration and nutrition. Ensure proper pain control, but avoid overuse of opioids, and improve sleep hygiene. Like I've mentioned, reduce nighttime disruptions. And these are the sources that I've used for this presentation. I hope everything was clear. I tried to make it like as much as I can, like straight to the point, very clear, very minimal, and I hope everything is clear. If anyone has any question.
Thank you so much, Dr. Nadine, for this excellent presentation. Thanks for sharing. Any questions or in addition, any comments? So delirium is very big topic in geriatrics and at the hospital. So when you do your, let's say, family medicine, then most likely you will be encountered.
I have a question, doctor, before.
Go ahead.
I'm sorry for the interruption.
No problem. Go ahead.
All right. Thank you, doctor, for a very nice presentation. It was very informative. My name is Red8, Dr. Red8. I'm a international medical graduate, currently on the process of USMLE journey. So my question is, how can we differentiate delirium from hyperactive or hypoactive? How can we differentiate dementia from hyperactive delirium? That's my question. Both, how can we differentiate dementia from delirium? The main differentiation to diagnose, just for the information. Yeah, thank you.
Thank you for this question. This is actually very important to differentiate between the dementia and delirium, as you mentioned. So, first thing that you
specifically hyperactive what? Hyperactive delirium.
Yeah. So, first of all, we can differentiate between them by the onset. So the onset of delirium is acute, usually hours to days, but it's usually more acute than the dementia. Dementia is a chronic and progressive process. It takes over months to years. And second of all, as I have mentioned, the delirium has a fluctuating and symptoms worsen at night. Usually it has like a sundowning phenomena, as they mentioned. And dementia has a gradual decline, relatively stable, usually on a day-to-day basis. Another thing, very important, I think, consciousness. Dementia, the patient has a clear consciousness until a very late stage where he starts deteriorating. Delirium, the consciousness, as I've mentioned, fluctuates, it's impaired. Patients can be drowsy or hyperactive. There's different types of delirium. So it affects his consciousness. And main important other differentiator is memory. So in dementia, usually memory is impaired, especially short-term memory. While in delirium, there is impairing memory, but how you differentiate it, it's the memory, fluctuating memory impairment. Also like reversibility. And like I've mentioned in the definition, if you recognize an underlying cause for the delirium, it can be reversible. But in dementia, it's usually a progressive chronic disease that is irreversible.
Yeah. Thank you so much.
That made the difference clear between.
Yeah, thank you so much. I raised this question because both of dementia and delirium it can affect both cognition and behavior. So it's very important to know the difference between them. Thank you so much. It was well informative. Thank you.
Thank you. Thank you very much.
Thank you both for the great question and excellent answer. Any other questions or any other comments, any other addition? Did you encounter any patients with delirium? If you did, can you raise your hand and tell us more about the case? So I'm going to share one case with you. When I did my internship, usually you will have two first-year residents along with a second-year resident. So my senior was an excellent one. So one day I came in the morning, they called me to see the patient. The patient is an older lady. She was confused. She was talking in different language, and she was on oxygen, but she kept taking off her oxygen. So he told me about the patient to go and assess, and we tried to use an interpreter to communicate with the patient to calm her down. And as you mentioned, if you find the underlying cause and if you can fix that cause, then most likely the delirium or the change in condition will be reversible. And that's what happened to that lady. So she was back to her normal or baseline after we treated, let's say, I don't remember the cause, but if it was a UTI, we gave her some antibiotics and she was back to normal. But the idea is that the patient may become fluctuating in the cognition or the communication with people if they have difficulty, they can return back to their mother tongue or the language they learn as kids. So, for example, I'm speaking English in the US, but I was raised in Sudan and I was speaking Arabic till high school and I learned English, for example. So if I have the delirium, then my brain will go to the default language, which is the Arabic. So if the doctor is asking me history, I'll be answering all my questions in Arabic and they need to communicate, so they need a translator. So this is what happened to that patient. The issue with delirium is at one point you may see the patient when they are lucid, when they are back to their baseline. And the delirium, as Dr. Nadine mentioned, it's fluctuating. So at one point, if the nurse calls you, telling you at night the patient was confused, was doing this, but you go in the morning and you see the patient was able to answer your questions and very like well looking and no signs of confusion. But as mentioned by Dr. Nadine, when night comes or evening, then the patient will get confused again. So it's kind of a cycle up and down. So it depends on the window when you see the patient. You may see the patient when they are confused, or you may come and see the patient when they are with it. So just pay attention to the history from the nursing staff if you are at the hospital, or from the patient family. They can give you a very good input. Anyone wants to share their experience? Please go ahead.
Hello.
Hello, go ahead, Dr.
My name is Ala. I volunteer at May Clinic in the program called DOVE, which is they have research in delirium patient. So my role, I go to the patient room who's they're like have a delirium stage 3 or 4, grade 3 or 4. So I went to their room I go to their room every week. I have 2 hours. I spend with them. The first things I do, I open the curtain, talk to them, turn the light on. So I do that every week. Actually, I don't know the research result, but they told us they like preserve some improvement in their like I don't know how to oh sorry I just I got lost. Sorry for that. I will share with you again.
That's okay. So I'm going to just elaborate a little bit on your comment. Thank you for sharing your experience. And one thing with delirium, when you're trying to treat a patient with delirium, is to understand their wake-sleep cycle. So most people will have the wakefulness, or they are awake during the day and they are asleep during the night. So if the sun is up, then they will be awake. Sun going down, then they will be sleepy or sleeping. So this is what we want the patient with delirium to have. So we don't want them to sleep during the day and be awake during the night. This is one intervention. So to do that, as Dr. Ala mentioned, we want to open the windows or make the sunlight in. So take off the window, make sure the light is coming in the curtain, for example, or during the night, you want to make sure the room light is turned off except small lights or dim lights near the floor, so they don't trip and fall during the night. Minimize the noises during the night. So these are two interventions that will help reduce the changes that happen with delirium, because the input, the light input or the sounds can intervene with the delirium. So our intervention is to reduce the light during the night, reduce the voice noises during the night, and during the day make them more awake by displaying or letting the sunlight come to their rooms, for example. You can get them active, you can get them into some activities in the hospital. They can take them to therapy, to the gym, watching TV, or engage with families and so on. So these are a couple of interventions for patients with delirium. The other intervention that I'd like to mention is minimize any added intervention that can be pulled. For example, an IV line, if they put them on IV hydration, for example, IV fluid, the patient may get confused and pull all the lights out. Or if they have a Foley catheter, if they can void without any problem, then you don't need the Foley catheter, take the Foley catheter out. So these are the intervention that you can minimize the risk of harming themselves if they pull lines out or Foley catheter out. So there are different interventions for patients with delirium, but the main idea is you want to understand its fluctuation, and at one point you may find them lucid. You want to redirect them, minimize any escalation. Thank you. Dr. Wafa, please go ahead.
Hello, everyone. Hello, Dr. Nadir. It's a pleasure to meet you again. I just want to share a short story regarding delirium. Happened to one of my relatives. And as Dr. Nadir mentioned, the most important thing in delirium is the history. Because when it happened to someone, he's my relative, and I was worried about the stroke. So I needed very good judgment in order to differentiate between delirium and stroke, because stroke is an emergency and need imaging and need further management. So be careful. Delirium and stroke can mimic each other, but the main differentiator is the history. Thank you.
Thank you so much for sharing, and this is a very important point as well. Thank you for highlighting that. And Dr. Fatma?
Hi, how are you? Thank you, Dr. Nadir, for all you are doing for us. Actually, during my work also at UI Hospital, for delirious patients, we prefer like sometimes we put a sitter because they can like be unstable and they can move around. And recently they found studies that it is better if they like, if we have like consistency in the people who take care of the delirious patients. And as you said already, like during the day and like the sleep cycle, but like most of them, like they need sitter. And if like it's so like sometimes they get aggressive or something, they can do like drugs also, like diazepam or anything like that. Thank you very much.
Thank you so much, Dr. Fatma, for raising this also important point. And this, I think, Dr. Ala mentioned some that if you keep consistency with people who are around the patient, and if the patient get familiarized with these people, then they will trust them, instead of every day there is a new person taking care of that patient. So they will get confused more and more the more people they are there. But if they have the same nurse or the same nurse aide at the hospital, for example, or a sitter that comes every day, for example, or better if they have a family member let's say a son, a daughter, that can come and spend some time with them. Then the patient will trust that person and will get calmer, and the intervention might be just that which help the patient. If they get confused, then you can use some interventions. Some of the interventions are not medications. We can use redirection. Let's say the patient wants to go home, then we will not say, no, you cannot go home. We will say, yes, we can take you home, but we are waiting for your son to bring the car so that we can go together. Something like that. Or the car is not here yet. We are trying to find the key for the car. And then as soon as we get the keys, we will go with you, take you home, something like that. So this is one way. If they are agitated and harmful to themselves or others, then we can use drug intervention medications like, as you mentioned, either anti-psychotic or anti-anxiety medication. So anti-psychotic, in the past, they used Haldol. Sometimes we use it now, or the next or second generation of antipsychotic. I have two hands, so go ahead, Dr. Salahuddin, and then followed by Dr. Reem. Thank you.
Hello, everyone. My name is Salahuddin Mohamed. I am currently an internship doctor in Beni Suef University in Egypt. So first of all, I would like to sincerely thank Dr. Nader for the opportunity to join this program and for this beautiful presentation. My question is regarding the differentiation between delirium and primary psychiatric disorder. So clinically, what are the key distinguishable factors between the delirium and the condition like schizophrenia and acute psychosis? Are there any specific assessment tools or approaches that can help in making an accurate diagnosis?
So, Dr. Nadine, if you are here, you want to answer, or I can follow up with the answer.
Yeah, I'm here. I think what I've mentioned before in the previous question actually goes for this question as well, like delirium versus any psychotic disorder. So the basic features of delirium are very unique, actually. The acute onset, the fluctuating, and the sundowning, worsening at night. I think those features are not present in any other psychotic disorder, which makes it unique. They actually being acute after being admitted to the ICU or after having a UTI, pneumonia. Having this kind of acute symptoms raises suspicion for delirium more than other psychotic disorder like schizophrenia, which actually needs having persistent symptoms for like minimum of 6 months, whereas delirium is more acute. Yeah, if you have anything else to add, Dr. Nader. You're on mute, actually. We can't hear you.
Thank you. Thank you for a great answer. Yes, so delirium is defined with certain criteria. And if you use the Diagnostic and Statistical Manual of Mental Illness, this is a book that DSM, I think the last one is 5, DSM-5. You will have each diagnosis with their criteria. So the history can give you a hint of how to differentiate, and Dr. Nadine mentioned some of the details, which is very important when you're taking history. So if you go by the criteria, you will save yourself a hassle. Thank you. Dr. Reem, go ahead.
Thank you, Dr. Nadir. Yes, so I want to mention my experience during my first year internship in a polyvalent service. So we faced a lot of patients that they have a delirium, especially after infections. And we noticed that especially the hyperactive form of delirium they don't respond to non-pharmacologic therapy. So we are obliged in the majority of cases to use pharmacological therapy, especially haloperidol, and we get results. Thank you.
Thank you so much for sharing. Yes, so it's important to know when to use these medications and the side effects and so on. So you can use more than one intervention. You can try the non-pharmacological intervention first and then follow with the medication, or you can use them hand in hand, both of them at the same time. The goal is to minimize the risk of harming the patient themselves or harming the staff or others. So if at one point you think the patient is harmful to self or others, then go ahead by all means to use pharmacological medication like Haldol and the new generation of antipsychotic, for example. Go ahead, Dr. Wafa.
Hello, I just want to mention that today I came across two papers using artificial intelligence and machine learning to predict the risk of delirium in hospitalized patients. This is a new way of doing research to predict. So they made, it was quite interesting. They made, I read two papers. The first one, they predicted short-term prediction using ML, which is machine learning prediction models. And the other one, they predicted up to 30 days. I found this quite interesting for predicting the risk of delirium. So delirium can be predicted according to the patient history and some variables.
Yes, thank you so much for sharing this up-to-date information. Yeah, delirium, I think one of the most studied subject, and in the past, Dr. Sharon, in a way, she is actually a nurse who started some of the work studying delirium and how to assess and how to prevent and how to manage. So one of the interventions that she used to, or she advised or encouraged people to do, is to risk stratify the patients as they come to the hospital, for example, or if they are going through surgery, for example. So there is a form or a scale that can be used for delirium. So you want to use that to minimize the risk or do some interventions so that you don't get to the state of delirium. That can be also used in ICU, for example. So there are a lot of studies in the past about delirium in the hospital and how to prevent them. One experience I want to share with you is in a city nearby Lansing here, in Grand Rapids. They have the hospital, and what they did is they used one floor for geriatric patients. So that floor, the staff will be at the same shift every day if they can, so that patients who are older at high risk for delirium or they have geriatric syndromes, then they will be admitted to that floor. And that staff will be educated about how to handle delirium and so on. So it's kind of a way or a new approach. So the idea of identifying the risk for delirium and minimizing them before it happens, I think that's a good approach. It's similar to the flu vaccine, for example, or other vaccine. So you don't want to wait until the infection happens and then you want to treat. If we can prevent it in patients that we know they are at high risk, that might be a good approach. Thank you so much for sharing this up-to-date information.
Thank you.
Excellent comments, excellent questions. Any other questions or any other comments? So in geriatric is very common, and it's very important to know about delirium. And there are a couple of questions about how to differentiate. So differential diagnosis lies in history. So the more details you get from the history, the better you will have the good chance to arrive to your diagnosis. Depression might be symptoms similar to, or might have some symptoms similar to delirium. Dementia, sometimes patients with dementia, although it might be an early stage, but at one point, if they have infection, if they have dehydration, if they have a fall with injuries, when they come to the hospital, they may be delirious. So they may have two conditions, actually. The underlying condition, the dementia, and the acute event with a trigger that causes delirium to occur. That also might be the case when you see patients at the hospital. And in fact, some of the patients who are diagnosed with dementia, sometimes they start the process of diagnosing these patients when they come to the hospital with some delirium, because the family members may notice some stuff going on, but they don't raise a red flag, or they don't raise a question to the family doctor. But when the patient comes to the hospital, then the staff there might ask more questions, and then they may find out more details about the patient decline, and then they refer that patient back to the family doctor or the specialist to diagnose dementia. So it may be a helpful situation when you see patient with delirium to get a good history, so that if they have an underlying condition like a dementia, you can pinpoint and raise the question or the concern with the other providers like a family doctor, or refer them to a specialist like either neurologist or psychiatrist or some, to help with other conditions. Thank you so much. If no more questions or no comments, we will go to the next topic. Any other speakers in the team that is ready to present any of the topics? So I'm going to go quickly on some of the topics. So the next one will be our, let's see. How to write a letter to the editor. For example, New England Journal of Medicine for future. So what happened in this topic, I want you to go over the author guidelines. So for each journal, there is a page where they give you details of how to write the article or the manuscript. So they give you some hints, and some do and some do not do points for you to go along. For example, if you want to write, in this case, a letter to the editor, they want the authors to be either 2 or 3 authors, not more than that. You cannot list 10 authors for just a letter to the editor. Usually the letter to the editor follows a major topic or a topic that of interest to you, that you might have some experience and you want to share your experience or your perspective or your update to that topic. For example, let's say Nadine now presented this topic about delirium, and she found a good article, and she want to write an update of that article, and she submit that article to the New England Journal of Medicine about delirium in, let's say, in Sudan, for example. So when I look at the article and read the new article that's written by Dr. Nadine about the delirium in Sudan, for example, I have some experience, and I can add to that article some of my experience in that topic. So I will write a letter to the editor, which is a short update, and most of the time it will be just an addendum kind of, or an addition to the topic, but sometimes it has some content that might negate or may contradict the findings of that topic. Let's say Dr. Nadine mentioned that most of the patients who are admitted to the hospitals are elderly and women. So in my experience, I will say, although Dr. Nadine mentioned that in her article, that the most patients were admitted were older and female, in our experience in what's, let's say, called northern part of Sudan, we found out that the number of patients admitted, female and male, are equal when it comes to delirium. So this is just an addition or highlighting or maybe contradicting the data mentioned by the article published in the journal. So this is how you write a letter to the editor. So either you add some more information, or maybe you want to highlight or contradict some of the information according to your experience. So at least you want to be expert in the field or in the topic that's raised. And sometimes it may be written by more than one author, as I mentioned. But the author guideline will give you more details. Now, with the use of artificial intelligence, this might also be a good tool when you are writing a letter to the editor. So it will help you outline and then take the points and arrange them in a way that's useful for the reader. Sometimes the resources or the references will be limited to 1 or 2, maybe 5. So the guideline will tell you how long is the list of references that can be used. And because it's just an addendum kind of approach, usually it's not a long list of references. It's just supporting evidence for you if you want to write the letter, if that makes sense. Any questions about this topic? Any comments? So I added some videos that will be helpful to the next topic, which is how to write a research abstract that will be accepted, for example, by AGS, American Geriatric Society, for a conference. So usually they open the door for submitting some abstracts, and this opportunity will be good for some of the fellows in this program. So if you want, the reference is here. It's kind of a video. I'm not sure, maybe 40 minutes. So when you have a minute, maybe you can look at that video, see what they are looking for. Sometimes they are listing some themes. So let's say they focus on certain topics or area of interest. And if you write an abstract matching to one of these themes, your chance will be higher to be accepted for your abstract. So one thing you can do is you can look at previous conferences and abstracts, posters that submitted and published. That will give you an idea of what areas or what themes they most likely will focus on in the coming conference, for example. The hot topics in the past few years about telemedicine, about the COVID for sure, but in the future, I think the use of artificial intelligence will be a very hot topic. So this is one thing you think about. So if you have a minute, I'll share the resources in the app. So if you look at the app, you will find the link and you can watch the video. The last topic I'd like to share is interactive use of maps, for example, US maps. And this you will be using when you are presenting some data. For example, you want to talk about a topic and you want to highlight some areas using the map. So I'm gonna give you an example. And this program, we have a lot of people applied and from different countries, and this is an online program. And we were successful in the past few years to have good fellows, and many of them matched to either residency programs or fellowship programs. And to highlight my point, if I go all the way here, I can show you, this is the map that showed every fellow who completed at least 1 year in our program and matched to either a fellowship or a residency program. So if you hit here, you will find this Dr. Ali Al-Khidir was here in 2020, and he finished 1 year. He applied for residency and he matched to internal medicine resident program in Minnesota, and he finished. Now he is, I think, applying for another fellowship after his residency. If you hit someone here, this is, for example, this is Dr. Samah. Samah, she is from Canada. She did her steps and she matched to a fellowship in geriatric. So you see what I'm saying? I can present using the map and I can give more details just by using the map. So how can we do that? So there are different ways of doing it. One way is to use Google Map itself. So if you go to mymap.google.com, you will come to this page. It's called Google My Maps. And if you go there, you will have an option of adding a map where you can add information. For example, in this tutorial I just showed you, I have a list of fellows who match to either residency or fellowship. So what I did, I added the list of the names and their location, the city and the state, and then I add that in a list and upload it to the, so if you go here on the right side or left side, upper corner, you will have all the items. I can hit here and then I can see more details about the information. So the information, I can import them from an Excel sheet and then update the items. So these all fellows, I have a list of their names, their location, and then when I upload or import that list, it will be published here. So I'm gonna try to show you the list. I think I have it somewhere here. So this is the list of the matched fellows, their names, their address, the program, and the year, and so on, the city and the state. And there is a way to map this. So there is a list of each city. It will be converted to a latitude and longitude number. So the vertical and the horizontal lines, these are the points that Google Map will use to indicate the location of the fellowship or the fellows or the residents in the map itself. So this is one way of doing it using my maps in Google. So you come up with a list and you just import that list to your map and it will be populated, and you can play around with the button on the tag of the small things. The other way to do it is to use online tools, and I'm gonna show you with this one here in a minute. So for example, this is an online tool where you can go to mapchart.net, and this is for the US map. So if you have it, you can click on any map, any state, for example, and you can change the color. For example, I want green, yellow, maybe green. I want to do like this. So in my case, I want to present the fellows who match to programs. That's, for example, a residency program. So I'm gonna do the residency program in red. And the other programs like fellowship program, I want them to be in blue, for example. So I have a couple of fellows who match to fellowship in Texas, in Nevada, in Florida, for example. So this way I can divide the map into areas where I can talk about, in my case, for example, the fellows who match to either residency or fellowship. A third way of doing it is you can download and then this. So you can use different ones that you can download and edit on PowerPoint. So you can download the map, and then in PowerPoint itself, you can update the map. And then this way you can also use the tool so that you can present and talk about your points, for example, or presentation. Any questions or any comments?
Thank you, Dr. Nadir, for your great effort. Thank you so much.
Thank you, Dr. Wafat.
Thank you very much, Dr. Nadir. I guess I want to add that I'm one of the applicants this year, and I saw many friends of mine, they done the fellowship last year, and I still, some of them, they active in the fellowship, and they get offer. They did very good in the interview. They get a topic to talk about in the interview about the fellowship and how is great the project for the research and the experience and all that things. It was very good experience for them to talk about, and they've been questioned about what they're doing and how that's add to them, to their personality, to their career. And I think it's priceless, or the meaning of this fellowship for all applicants here is just something is amazing, and really thank for that.
Thank you so much for sharing this kind words, Dr. Osman. I'm very glad to hear this good news. So it's a unique program. So we want to help you, and the idea is to empower you and be on the same level as competitive as graduates from the US schools. So I know it's not fair. You go to the same school 5 years, 6 years, and then come back and you do the steps. But at the end, they will select most of the residents from the programs or the schools here in the US versus someone who is coming from overseas. So this way we can try to empower, enhance your resume, improve it, and hopefully it will help you get selected for the interviews. And hopefully when you do the interview, you will be talking about the program, and as Dr. Osman mentioned, you will be a unique, and hopefully you will add some good stuff to the program. Thank you. Dr. Abdullah, go ahead.
Assalamu alaikum, Dr. Nader. How are you doing?
Good, thank you.
Yeah, thank you for helping us with this fellowship. I just wanna, as you said, they affiliated by Michigan University. It's removed. So are you like willing to share maybe like no affiliation with the other like university in the future maybe?
We plan to start some affiliation, and for some in the past, if you need or someone needs some headed paper with some institutions, we have Dr. Ahmed Dawanur. He is also one of our faculty in this program. So if needed, we can talk about Mayo Clinic. They can offer some help. But at this time, I'm sorry, we don't have connection with MSU. Maybe in the future, or maybe in the future we can connect with other institutions. I think it's important for the fellowship to be recognized, and for you as fellows to have some institutions that you can put in your resume. But we are working on that. Thank you.
Thank you, Doctor.
Any other comments? Go ahead, Dr. Osman.
Sorry for commenting a lot, and I don't know if that's the right time to ask about the project or keep the question for project at the end of.
Yes, I think, let's see. I think that's topics that I wanted to talk about. Yeah, so the last one topic is an update. So if you want to go ahead, if you want to talk about any of the research topic, go ahead, please.
I'm in a group, Project 70, and I'm been busy over the last couple of weeks with interviews and stuff like that. But I feel now I have more time to just be actively more involved and participating. But I found my groups, I don't know, the leader. I try to reach out to other group like we're red group. Dr. Omar, I reached out to him. But I think there's different projects, and I saw some people there in 2 projects or so. But our project 70, there is no kind of activity there when I reach out to see how we're gonna start, how we're gonna put things together. I'm just concerning about that to see. There's 8 members in the group, and just want to see how things will go. So we're not gonna delay the project, or if not moving forward, just to like for a member to participate in others, or just to reach out. We don't like to be in a lot of people in one project. As you say, when they do the publication, there will be limited number and so on. How you can see, what's your comment about that? Thank you.
Thank you so much for raising this point. And for the new fellows, I'm gonna just go over some of the basic steps to highlight the question that Dr. Osman mentioned. So each fellow, we expect you to get involved, and hopefully you complete a research project from A to Z, or at least you know the steps to do that. I'm gonna go over the steps in a minute. But for you to join a research project, you can jump into an ongoing research project. For example, some people started a new idea and they already started working on getting some data. You can join that team and then work on either analyzing the data, finalizing the edits, submitting the, let's say, the manuscript, if it's a manuscript, or the abstract. Be an active member of that team and If you want to present, you can do that as well. So there are different tasks during the process of working on a project. You can handle one or more tasks along with the team members for that project. So for you, you can start just in the middle of an ongoing research project. The other option is to start your project from scratch, or if you have a new idea or research question you want to start, you know how to, you can come up with a research question and then build a team and then divide the task so that the team members can handle some of these tasks, and hopefully you will complete the project together in a timely manner and submit that, and hopefully you will present that. Or if it's a paper, you can submit to a manuscript as a manuscript, and hopefully it will be published. So there are two ways. The first way or method is to jump and join a team. And most likely, most people will do that if you are new to the research area and you did not do a lot of research in the past. The other route or the other method is to start if you already know how to, or you did some research work in the past. But in any case, we want you to know the steps. So the first step in writing or starting a project, a research project, is the research idea. And I'm going to share with you in the app here. We want you to go over some of the basics. And hopefully this will cover some of your topics when you are doing a research and you know the research area. So you want to make sure you know your ethics before doing anything. But the research topic, if you want to start a research, we have a list of suggested research topic. If you go there, it will have some of the possible research project and the number of fellows in that each project. So for example, I want to start a new idea, but I don't have the idea. I just want to start a project. You can go to number 37 here and you can add yourself. You can add yourself as a leader or co-leader or just a team member, and then submit. Or you want to work on what area? I want to work on presentation, for example. And this will have a list of the members in this project. So some of these, they have a link file where you will have some basics, like I used artificial intelligence to write how we can get the background, the method, and so on. This is where I want you to focus on here. So when you have the topic, you want to find a research gap, and hopefully you will have a topic that's of interest that you are doing about that gap in the research area. So this is what we call a research question. If you find that research question, the next step will be how you want to do your research to answer that question. There are different methods for different questions. So you want to know the methods before you want to start the project. Let's say I want to do a survey for medical graduates from India about elder abuse. So this is the idea. So the method is collecting data using a survey method. So I'm going to use Google Forms, for example, to build the form and then distribute that form to collect the data from people who have graduated from India, for example. So this is the way of doing the research. Then when you have the method, you want to identify the variable of the data that you want to. So for example, I want to ask in the questionnaire about their age, for example, age range, sex, gender. I want to see what part of India they graduate from, for example. So, and then the question about elder abuse, what they know, did they experience any during their school or after they graduated, when they work in hospitals in India, and so on. So I have a list of questions, let's say. So you build these questions, and mostly the team will discuss between them themselves about which question is good enough, which one we need to remove, because we don't want a long list of questions in a survey, because we know most people will answer few questions, but if you have a long list, they will get tired and they may not give you the whole answers for all questions. Let's say that's the case. So you agreed on developing the survey, you agreed on collecting the data with certain questions. Then when you collect all the information, you will analyze this information. So some of the fellows will be working on analyzing this data and so on. So these are the basic steps to identify an area, identify a question, identify a method, identify variables to collect the data, identify how you collect the data and how to analyze this data. So this is the first half, let's say. The second half will be who will be writing all this, collecting the result analysis and conclusion, and finalize that into, let's say, an abstract that we want to submit to AGS, for example, American Geriatric Society. So maybe 2 fellows will be working on that. And then 1 fellow will be submitting and communicating and see if this get accepted. And then if get accepted, then they will be working on developing a poster so that they can present that poster in the conference. Sometimes they want you to be in person for that conference. So I prefer, if that's the case, one of the team hopefully will be located near the area where the conference will be. For example, in March, next month, there will be AMDA conference in North Carolina. So it's preferred that someone from the team will be located near that state, or at least they can travel conveniently to that state, because it's going to be a cost included. So unfortunately, this program, we don't have fund to support you to go to a conference. So the group themselves will share and then will pay for that person who will be presenting in that conference, or it may be out of pocket for that person, whatever the team will decide. Then you present, and then you'll put all this in your CV, for example. So the conference in North Carolina, it will be Charlotte, and the name is AMDA, AMDA, which is American Medical Director Association. That's an old name, and the new name is Subacute and Long-Term Care Association. So it's post-acute and long-term care association. It has the medical directors, mostly physicians, but also they have members who are nurse practitioners or physician assistants. So the conference is a very big conference, and people can learn a lot. They accept residents, fellows, and sometimes medical students. They can also present in this conference. They can present posters, sometimes oral presentations. So this is how you develop the whole process of a research project. So Dr. Osman, you mentioned the project number 70, for example. Is that correct? Okay, so let's see.
70, yes. Right.
70, if I can get the 70. So healthcare provider training and support for telemedicine long-term care, systematic review. So let's see, 70 again. So it has 8 people are involved in that, or at least they added themselves. So what I would suggest for you, Dr. Osman, is to identify the people who are here. So these are their email addresses. You can connect them via email, or if you want, you go to each one and you will find their name. Let's say Huyam Babikir. If you go here, you will find the junior or seniors. I think she's a junior. If you go Babikir, no, maybe she's a senior. You can go to senior. No. Oh yeah. For some reason, it didn't show up, but you can find the person, let's say Osman, for example, or one of the seniors here. Let's say Hassan is one of the person interested. If you click on the person and the fellows, you will find their phone number and email. If you want to send them an email or a text message, or if you want to call them, that's an option. So this is how you get contact with your other members in the field or in the project. Hopefully, one of you will be available to lead that project. Let's say, Osman, you already done with your exams and you have some time. So maybe you will be the leader if you are interested to lead that project. So I'm gonna call you the project manager. So what you will do is you get the information about your team members. Some of them may be available, some of them might not be available at this time. Some might be available in, let's say, April. So from now till April, you will not include them in the process. You will not give them tasks, but you will give them tasks after April. So the task you want to divide them into the first step. So we have the title. The second step is you want to identify the data bases. Let's say you want to look at Google Scholar, you want to look at PubMed, you want to look at Cochrane, for example. These are three of the databases. So you identify some of the available fellows and select two of them. Tell them we want you to look at this data set and collect all information about this topic. The next question is how they gonna do the search. They want to identify the keywords or the terms that they want to use to get the information from this data set. So you identify these keywords and then submit. And then when you get the data, maybe another two fellows will be working on cleaning the set of data that collected. So you will have a spreadsheet, and then on this sheet, you will say, this study is good, this study will not include because whatever reason. And then you will have a shorter list of studies about the topic. Then you want some people to summarize these studies, for example. So in the spreadsheet, the included studies will have some summarized text about each one. And then you could categorize these findings or these summaries into, let's say, themes. So the first theme will be this, second theme will be this, third theme will be this. A very simple example, let's say, about telemedicine. People will love it, other people will hate it. So in your studies, you will have some summary of the studies that people are hating telemedicine. On the other side, in your summary, you will say these people are using or loving telemedicine. So at the end, you will have the list, you will have the summaries, you will have some themes about the topic or main ideas. After you've done all this, then one or two fellows will collect the summaries and write the abstract. So in the abstract, they will say, we use this method searching this data set. We collected how many numbers of studies. We selected according to our inclusion criteria these numbers, and we excluded these numbers. And out of these selected articles or studies, we found, then you mentioned the themes. So theme number one, we found that these studies agrees with whatever or disagree with whatever. So your findings according to what you found in these studies. After you write this, then you come up with what you think is the final conclusion and the direction, the future direction. So you write this. So some of the fellow might be available to write this down, and then you submit this to the conference and hopefully will be accepted. If you go to the app again, home, if you go along, so this is one of the conferences. They are open for abstract. So it's called GSA, which is the Gerontological Society of America. This is their annual meeting that will be in Boston in November. So they are accepting some of the abstracts. So if you are interested in submitting to this conference, look at their themes and see if it matches your topic, and then maybe with your team members will work on getting this ready and submitted. So to do that, as a manager, you want to identify the task. You want to divide this task between the available fellows now and then some later on, and put some deadline. So let's say in 2 weeks, I want this to be done. Let's say work on getting the data and the analysis. Then in the next 2 weeks, we want to finish the inclusion, exclusion, and the summaries. And then by the end of the month, we will have this ready. So the next group of fellows will be working on writing according to the findings. So in 2 months, for example, we'll be having all this ready to be submitted. This is how we do the research project. So the manager will direct the fellows. He or she knows who is available from the fellows, so they can give them the task, and who is not available at this moment but will be available down the road in the future. Then they will give them the lead task. For example, some might be able to present in the conference or online, or maybe some will be available to do the poster like in a PowerPoint or some design. So this will be their task if the abstract is accepted, and so on. Any questions or any comments or any suggestion?
Thank you very much, Dr. Nadir. I think I will take the courage to take that position to be team manager and collect the team together, and we can get something. And I guess I want to share that something. I have access to library here in University of Iowa. So if some people, they want to get some data extraction or anything there, they can reach out to me. I can help them through the keyword and search their things and get that study or something like for them out.
Sounds good. Thank you so much, Dr. Osman. And I'd suggest to you, Dr. Osman, is to look at a tool. It's called Ryan, R-Y-A-N. Are you familiar with this tool?
No, Ryan.
Ryan.
Yeah.
So it's a systematic review tool, and I think it's very helpful. There are other tools that can be used, but this one, we have a video about how to use it. So in the app, if you look it up, you will find some videos or in YouTube, and you maybe 40 minutes, 50 minutes but it will tell you the steps so that you can understand what is involved in writing a systematic review. I gave you a summary, but it will be helpful, and there are other tools that also can be used, but we can start with this.
Thank you very much, Dr. Nadir. Appreciate that.
Thanks. Any other comments or any other questions about this topic or other topics? Please raise your hand or go ahead.
Dr. Nadir, you are muted.
Thank you. I just want to share with you that one of the fellows in this program, Dr. Faiza, sent me an email 2 days ago about good news that she wrote a case report and that was accepted in one of conferences, AGS, that coming in May in Chicago. So good, and congratulations to her and her team. And I also want to share that at least 2 abstracts were submitted to the conference in Canada. It's called NAP-REC, which is North America, primary care physician of in North America. That also were submitted, and we are waiting to see. Hopefully we'll hear good news. So congratulations to all those who are working and submitting, and to those who got some good work and acceptance. So I'll open the floor for the new fellows. If you have any questions or comments or anything about the program, please raise your hand or tell us your name and your question or any comments. So anyone with new ideas for the research projects, anyone wants to start a research project? Do you have any questions, research question? Okay, Dr. Hiba, go ahead.
Hello, Dr. Nadir. How are you? Assalamu alaikum.
Alaikum salam.
So it's not a new project. It's a project that I've emailed you and I got the approval from you. It's about the research directory, if you can recall. The idea is, you are muted, Dr. Nadir.
Yes, go ahead, yes.
So the idea is to start a directory for the new fellows. It might be, as you have mentioned, a website or a PDF file, can be sent to the acceptance email. So the new fellows will know what is ahead for them and what they are waiting, how to get the most beneficial thing from the fellowship, to understand what they are required and what we are asking from them, what the fellowship is asking from them, how to interact and how to, in simple, about all the secrets and how to get the best benefit from the fellowship. So I was in the idea of choosing the members, and I believe it's more for senior fellows and for professional ones. The most senior ones, maybe from batch 1 and batch 2, because they know they were here in the beginning of the fellowship program. Also, I might need people who are familiar with the digital designing, and they are maybe a professional with that discipline. So here I'm asking for fellows who are interested in joining this project to be part of it. If you have any experience with if you have any experience with the process of content creation, I guess, and also the visualization, designing a magazine or anything like that, that would be helpful. Maybe I will send a draft by tomorrow, inshallah. It's about the tasks and the people who will be assigned to them. So if anyone is interested, that would be great. Thank you, Dr. Nader.
Thank you so much, Dr. Hiba, for sharing and taking the initiative for this good project. It's an excellent idea. So if anyone interested in building the initial blocks for this project, please go ahead and contact Dr. Hiba. Any other comments?
Thank you.
Thank you. So Dr. Hiba shared our email address in the chat. If you want to contact her, please feel free. So if there are no more questions or comments, then I'd like to thank you all. And I'd like to thank the presenters from today. Great, and thank you for your effort. And I'd like to thank all who attended the meeting today and who will be watching the video in the future. Have a wonderful day. We'll see you next week. Email me, contact by text or call. I'll be happy to answer and help as much as we can. Thank you again. Have a good day. Assalamu alaikum.